ايش اخذ في ارجع مرة ثانية شعر؟
لا تمام بس ايوه خلص. جو باك للسلايدز.
اللي هي وين؟
هاي بالضبط.
هاي تتأكدي انها موجودة؟ تمام، شكرا. الله يخامسي، مساء الخير، كيف حالكم؟ لو سمحتوا خلينا نبلش التوبيك تبعنا. اوكي. كويس هيك؟ تمام. Okay, so last time we talked about class 1 malocclusion, and we talked about the different definitions and terminologies related to class 1. أموركم تمام؟ يلا. Right. وحكينا عن etiology of class 1 والocclusal features، بعدين كيف بشكل عام نطلع البروبلم list، التريتمنت objectives والتريتمنت بلان، تمام؟ وبلشنا نحكي عن special clinical cases. هلا لما احكي انا special clinical cases مش معناته انه هدول موجودين بس بكلاس 1، لا طبعا. الكراودنج والسبيسنج سواء generalized ولا localized ولا displaced teeth والvertical disability كل هدول ممكن يتواجدوا ب other types of malocclusions. بس لأن class 1 anterior posteriorly almost average normal فأسهل إن نركز على one problem. إذا بلشنا نحكي class 2 division 1 حنبلش نحكي على أشياء ثانية، فبلاش نخلي المواضيع السهلة هلا وبعدين نبلش نركز على ال other types of malocclusions. فlast time we talked about crowding، المرة هاي رح نحكي عن الspacing. هلا الspacing ممكن يكون generalized أو localized. كيف بعرف؟ بتطلع على الستادي موديل وبعمل space analysis. إذا طلع عندي minus معناته crowding، إذا طلع عندي plus معناته spacing. تمام؟ هلا generalized spacing is a bit of burden in terms of orthodontic treatments. It's difficult to treat لأنه retention difficult و relapse is sometimes dominant. فالواحد بده يفكر بالنهاية قبل ما يفكر إيش بده يعمل. At the end retention مهم صح؟ It's an important part of treatment. إذا كان retention، إذا كان الكيس prone to relapse معناته الكيس difficult. هلا السبب أهم أسباب generalized spacing اللي هو tooth size arching discrepancy related ل small teeth اللي هو microdontia أو missing teeth اللي هو hypodontia. زي ما حكينا it's difficult لأنه في عنا relapse. هلا بالmild cases we encourage the patient to accept. ما في داعي نعمل orthodontic treatment. بالmoderate cases إذا كانوا الأسنان شوية microdontia صغار نسبياً بالنسبة لوجه البيشنت وحجم بقية أسنانه إلى آخره، then we can suggest إن نعمل aesthetic workup, veneers, composites, crowns accordingly. أما إذا كانت severe, for most probably we will have to go with orthodontic treatment plus restorative treatment. So with orthodontics we close some spaces, we localize other spaces, and then we think of prosthetic replacement. So implant, bridge, fixed, removable, auto-transplantation to replace or to camouflage the spacing. Like this case here, for example, we have mild spacing. It does not really affect patient's aesthetics, so we encourage the patient to accept. So we go with accept. This patient here almost the same amount of spacing, but it does affect aesthetic and it does affect function. So actually here we offer the patient treatment, mild. We look at the size of the teeth, they look normal, so we don't offer restorative treatment because the size is good. So we go with fixed lines, alignment level, closed spaces. So just close spaces and think about retention carefully. Severe cases, moderate cases where we have spacing that affects aesthetic. Again, teeth are acceptable, but laterals are are small, so we can offer the patient build-up with laterals plus closing the spaces with orthodontic treatment. The patient was happy with her small laterals, so we just went with orthodontic treatment only. Now, here are severe cases where we have microdontia in addition to hypodontia, where we have congenitally missing central incisors. These are the 10 days. These are the 10 days we have congenitally missing central incisors. So this case could never be treated only by orthodontic treatment. And acceptance is not an option because it does affect aesthetic. So what we do is both. Orthodontic treatment to close some of the spaces and localize the space for future prosthetic replacement. So this is after treatment and the patient is old enough for implant or if she wants bridge, whatever the prosthetic option is. Now, if we talk about localized spaces, the most common etiological factors, hypodontia, congenitally missing teeth, lost tooth due to trauma or extraction, lower frenal attachment. We'll talk about each case. Actually, we're going to group these two together because the treatment options are almost the same. Hypodontia, you already know the epidemiology looking at the Jordanian population and the Caucasian population. You already know the distribution and the most common teeth affected by hypodontia. So it's just important to know that mild cases, usually 1 to 2 missing teeth, 3 to 5 missing teeth, moderate hypodontia, 6 teeth and more is oligodontia or severe hypodontia. Patients with missing central incisors, if a patient comes to your clinic with a missing central incisor, then most commonly this is due to trauma, mainly due to trauma. Fresh trauma now happened or trauma during the next dentition to the deciduous teeth, causing dilaceration or impaction, extraction, etc. Congenitally missing is very rare for central incisors. So this is a case where the upper right central incisor dilacerated, very high near the nose cavity. So this is severe impaction, and the only option is extraction. So you will end up with a missing central. Missing lateral incisors, on the other hand, most commonly due to hypodontia, congenitally missing. Trauma, less common. So the first thing I think about is hypodontia. But at the end of the day, we'll end up with a missing tooth. So whether hypodontia or extraction or trauma, loss due to trauma, the end result is that I have a missing tooth. Treatment options, 2 main treatment options. I have to decide, should I close the spaces and camouflage the rest of the occlusion as if this tooth never existed? Or do I open space for a prosthetic replacement? This decision is very important and it is affected by multiple factors. The skeletal relationship of the malocclusion, smile line, crowding and spacing, so this is a space condition, number of missing teeth, color and form of adjacent teeth in case I want to camouflage it to look like another tooth, this is important. Inclination of adjacent teeth because this will affect the type of tooth movement and the type of tooth movement will affect the type of appliance and the treatment duration. Desired purpose-segment relationship at the end of the treatment. Patient wishes and cooperation is very important. And finally, long-term maintenance and replacement of prosthesis. What am I going to do the next step? The option of space closure, usually these are the features that favors space closure, especially if I have missing upper incisors, citrals or laterals. Patients with a class 2 skeletal pattern, crowded arch in the upper arch, of course, increased overjet, small canines with good matching color. When we say matching colors, it means matching the rest of the centrals that are there, or laterals. So a canine that is not canine-ish in shape, that is not bulky, yellowish, no, this will not favor space closure. Okay? Class 2 buccal segment relationship, more than half unit. So this is an example of a patient. One of the lateral incisors, microdontia, the upper left one, and the upper right one, congenitally missing. In addition, in the lower artery, this is complicated by congenitally missing second premolars. The patient has class 2 skeletal pattern and increased overjet. Missing second premolars, missing lateral on the right side and small lateral on the other side. Class 2 skeletal pattern, increased overjet. These two features favor space closure. We decided to extract the lateral on this side and use the space to camouflage the underlying skeletal pattern. Space closure, and this is the patient at the end of the treatment. And on the other hand, or maintaining if it's already there are other features that favor space opening. Class 3 skeletal pattern or class 1, spaced arch, bulky dark canine, class 1 buccal segment or class 3. All these features favor space opening. Example, this patient here, she has congenitally missing upper right lateral incisor. She presented with a class 1 malocclusion on mild class 3 skeletal pattern, and the molar relationship is class 1. So all these features favor space opening, the class 3 skeletal pattern, the class 1 molar relationship, and the spaced arch. So the treatment is to open space here, localize all the spaces and open space for the missing lateral incisor. Actually, I opened space, and this lateral is a prosthetic one I added to the arch. This is a prosthetic one. Can you see? Yeah, so if this is a prosthetic one, center line spot on, good occlusion, overjet, overbite, everything looks good. So I take a radiograph to make sure that the roots are positioned properly for a future implant. So when I see parallel roots, that's it. This is the end of my treatment. So remove the appliance, and this is the Essex, vacuum formed Essex for retention until the patient is ready for her prosthetic replacement. So there are different features that look at space opening or space closure. Now, to have a successful implant, there are certain criteria that I need to look at. The patient should be finished growth, so this is 18 years and above. Sometimes the surgeons prefer 19, 20, the older the better, because some patients will have residual growth, and that will lead to vertical displacement of the implant. Adequate bone height and bone width, and adequate space between the roots and between the crowns. All these features will give you a better success of your implant. Implant is not the only option, but we also have autotransplantation. Autotransplantation, that means I use an extra tooth that I don't need within the patient's arch or within the patient's mouth, and then use it to fill a space of a missing tooth within the same patient's mouth. Autotransplantation. The advantages: biological replacement, so I don't need prosthesis, creates alveolar bone, has a natural periodontal membrane and better gingival contour in theory. It can erupt in synchrory and adjacent teeth if we use this technique in a growing patient, where the root is not fully formed. This could be possible. Can be moved orthodontically once healing complete, and it's suitable for growing patients. I don't need to wait until the patient is above 18. I can do it with a growing patient. So this is an advantage. This advantage is only if a tooth planned for extraction, because not every patient has an extra tooth. Not every patient has crowding. Increased burden of care and general anesthesia required for the procedure. Requires a skilled surgical technique. The surgical technique has to be as atraumatic as possible to be successful, otherwise we will have failures. Transplanted tooth may undergo resorption and ankylosis. Right, criteria for successful autotransplantation. Ideally, root development about 2/3 to 3/4, not complete. Okay, not a complete root, 2/3 to 3/4 completed root only. Sufficient space in arch and occlusally accommodated transplanted tooth. We prefer to put it out of occlusion so that we don't have occlusal forces against it. Careful preparation of the donor site with as atraumatic procedure as possible. Careful surgical technique of extraction. Transplanted tooth should be splinted 7 to 10 days, and this should be followed by root canal treatment. It is not not an ideal case, but this is the only case I have with auto-transplantation. So this patient presented with, of course, she's an adult patient who presented with a class 1 malocclusion complicated by multiple crossbites and crowding. This was complicated by a missing upper left first premolar, right? Graph, we were surprised to have an extra premolar in the lower left quadrant, a supernumerary tooth. Guess what? Auto-transplantation, why not? So we started with correction of the features of the malocclusion, correct crossbite, open space, so this is a space opening, open space for the donor space here, and then we made sure that the roots are parallel. There is enough space between the roots, enough space between the crowns, and by that time the tooth had a fit-up and it actually erupted. So that was good because the extraction procedure was as atraumatic as possible. So this extra tooth was extracted and it was inserted inside the donor side. It was out of occlusion. This was followed by endo treatment, and of course this should be followed also by maybe crowning, restorations, and the restorative composite may be built up. Now the last case of localized spacing is median diastema. When we say diastema, it means the space between two adjacent teeth. If it's between the centrals, then this is median diastema. It's more common in the upper arch, it's more common in males, and it's more common in Black ethnic groups. During the normal physiological stage, during the deciduous dentition, it's normal to have spaced deciduous teeth. During the next dentition, it's normal to have what we call ugly duckling stage, when the canines start to erupt, pushing against the lateral surface of the deciduous teeth, the distal surface of the lateral incisor. We will start to have flaring of teeth, and part of it is diastema. So this is normal. So if this is the case, then we have to reassure the patient that this is a normal physiological development. We don't need to provide any treatment. Another etiological factor for median diastema is congenitally missing lateral incisor or small lateral incisors. Supernumerary tooth, like the mesidens, or maybe tuberculate inside the bone, intrabony lesion or pathology, or to generalize the spacing, proclined upper incisors, or low upper frenal attachment. So by maxillary proclination, both are proclined or low frenal attachment. To be able to properly diagnose a low frenal attachment clinically, we could go with the Langshan test, where we have whitening in this area here, and we could add this with a periapical to look at the vertical notch to make sure that actually the insertion of the fibers is inserted between both central incisors. Management. We always need to exclude supernumeraries. Any patient with median diastema, we take family history, we take radiograph to exclude supernumeraries. If it's there, then extraction and monitor and reassess need of further treatment. If the patient is within the ugly duckling stage, as we said, reassure as long as the diastema 3 millimeters or less. But if it's more than that and it's really affecting patient's self-esteem, confidence levels, he's really bothered with it, then we can go with a simple treatment, depending on the orientation of the central incisors. If they are upright or flared distally, tipped distally, then we can provide the patient with a simple removable appliance to tip these teeth mesially. Simple removable appliance with belated finger springs. If the teeth were mesially tipped already, then we need bodily movement. That means the only option is fixed appliance. We need to be careful because the canine hadn't erupted yet. We don't want to compromise the roots of the centrals and the laterals against the erupting canine. If this happens in the permanent dentition, so if we have median diastema in the permanent dentition, if it's mild, then we encourage the patient to accept. If it's moderate and there is small teeth, then we can offer the patient restorations to build up. If it's more severe, if it's moderate and the size of the teeth is normal, then we can offer the patient tipping movement or fixed appliance based on the orientation of the tooth to start off with. Finally, severe cases, we need to offer both orthodontic treatment and restorative camouflage of the small teeth, because usually this is part of the etiology. What if the low frenal attachment is part of the etiology? What do we do? When? There are 3 proposed times: before treatment, orthodontic treatment, during, or after. The best time is during or after, never before, because if you carry out the procedure before, you will end up with scar tissues, and moving teeth across scar tissues is very difficult. So it's important to start closing, make sure that the patient is really complying, you're almost closing it, and then you go with frenectomy. This will actually build scar tissues around the new position, and this will aid the retention. So timing of frenectomy is important. Retention is extremely important to consider, especially if the patient has family history of diastema, median diastema runs in the family. If the diastema is more than 2 millimeters at the start of the treatment, or if the arch was already spaced at the start of the treatment. These 3 cases, really you need to consider retention, permanent retention, long-term retention, bonded retainer. This is an example of a patient who suffered diastema both in median diastema in the upper and in the lower arch. And because of the orientation of the teeth, the only option was fixed appliance. So we closed the diastema, and of course we added bonded retainer for retention. So diastema treatment to diastema will depend on the severity, the age of the patient, and the dental development. Displaced teeth is part of the crowding, but I have to add a slide here just to tell you that displaced teeth is not only due to lack of space, but there are other etiological factors. Abnormal position of the tooth germ, retention of deciduous teeth. For example, this canine here, there is a deciduous canine, so it was forced buccally. There's a deciduous canine, so we have some crowding, not because of the deciduous canine only, but because we have tooth size outline discrepancy. But it's part of the problem. It could be secondary to presence of supernumerary, or due to habit, or due to pathology. Whatever the etiology is, we need to go back to crowding, assessing of crowding, and deciding on extraction accordingly. Displaced teeth or crowded teeth, the same treatment strategy. Vertical problems. Vertical problems could exist in many types of malocclusions, but as I said, we're going to discuss it here because it's easier to discuss one dimension rather than anterior-posterior problems as well. Vertical discrepancies is the lack of vertical overlap between the upper and the lower incisors. The anterior orbit, usually due to skeletal problems, and this is related to posterior growth rotation, increased lower facial height, increased maxillomandibular plane angle, Frankfurt mandibular plane angle, in general, increased vertical proportions of the face. It could be due to soft tissues like endogenous tongue thrust or exogenous tongue thrust, adaptive swallowing pattern, or incompetent lips. Of course, incompetent lips will lead to bimaxillary proclination, and proclination will lead to reduction of overbite, vertical overlap, maybe up to the extent that we have anterior open bite. Of course, it could be due to habits, thumb-sucking habit, and the severity will depend on the duration, intensity. Usually it is asymmetric and it is associated with posterior crossbite. You already covered that with the local factors and soft tissue factors. Localized failure of development, like a cleft lip and palate patients, or mouth breathing, where we have little evidence to support this. Now, what is the management of anterior open bite? Again, anterior open bite is a little bit difficult, so we need to look at the etiology. We need to plan this case carefully. If the case is in the mixed dentition and it is related to thumb-sucking habit, then it's extremely important to stop the habit first and maybe add habit breaker, fixed habit breaker, or removable appliance to start expansion, and that could reverse most of the features except for the crossbite. If thumb-sucking habit existed in the permanent dentition, again, we need to stop the habit first, but the treatment of the features of the malocclusion should follow a comprehensive treatment plan and usually fixed appliance plus minus expansion. problem is in the permanent dentition and it's mild, then again I need to encourage the patient to accept, especially if we have persistent poor oral hygiene, not compliant patients, not a satisfied patient with his occlusion, he has no problem with his occlusion, or persistent habits, the patient is not willing to give up his thumb sucking habit, or indigenous thumb thrust. If this is the case, we need to encourage the patient to have no treatment. If the patient is still growing, then the patient is usually following a vertical pattern of growth, posterior growth rotation, so maybe we need to keep the patient under brief observation to look and assess growth pattern for this patient. In mild cases, we could go with extrusion of labial segment plus minus intrusion of the buccal segment, but favorably or ideally we go with the intrusion of the buccal segment using hypo headgear or fixed appliance techniques, buccal capping with removable or functional appliances, repelling magnets, which is not that common nowadays, temporary anchorage devices, which is the mini screws that we use in orthodontics. In moderate cases that is associated with anterior-posterior problems, especially class 2 problems, we could use functional appliance plus hypo headgear or bite blocks to control the vertical dimension. If bimaxillary crowding and proclination exist, and there is crowding as well, then we might consider extraction and retroclination of the upper and the lower incisors. Retroclination will affect the vertical dimension. It will increase it. So this might be the answer of the anterior open bite. Severe skeletal open bite, we should always consider orthodontic surgery. So this is an example of a patient, normal vertical proportions, class 1 malocclusion, complicated by anterior open bite. Why? Normal vertical proportions. Bimaxillary proclination. Can you see here the upper and lower teeth? Bimaxillary proclination. Looking intraorally, the decision, in addition to the crowding, so this is a case of bimax, crowding, anterior open bite. Extraction of both 6s in the lower arch, the 6 in the upper left quadrant, and the 5, because this is a failed endo-treated tooth. Extraction of the 5 on this side, fixed appliance upper and lower, closure of space, control vertical dimension, and this is the patient at the end of the treatment. So we didn't think of orthodontic surgery because the patient has normal vertical proportions. So the answer is dentally. Let's compare this with the previous case. Do you think this is more severe? Etiology. Skeletal. This is a huge vertical proportions. Posterior growth rotation, increased lower facial height, increased vertical proportions in terms of maxillomandibular plane angle, Frankfurt mandibular plane angle. This is a skeletal, we call it skeletal open bite. Full stop. This is not dental. So the only treatment to offer is orthodontic surgery. So we start with fixed appliances to arch coordinate, close some of the spaces, and then this is the patient at the end of the orthodontic surgery. So the treatment, we need to understand why this happened, we need to understand the etiology, and then plan our treatment accordingly. Now we will come to a problem in the transverse dimension, which we call crossbite. Crossbite is usually a discrepancy in the local-lingual relationship. You need to answer 4 questions for any crossbite in the buccal segment. Is it lingual, which we call it scissor, or is it buccal? And this is based on the lower buccal cusps. If the lower buccal cusp is more buccal to its normal position, we call it buccal crossbite. If it's more lingual to its normal position, we call it lingual crossbite or scissor bite. The other question is it unilateral or bilateral? Is it localized to few teeth or is it generalized to a whole segment? With or without mandibular displacement? Any unilateral crossbite, you should think about mandibular displacement. Bilateral crossbite, less common to have a mandibular displacement. So this is the normal transverse relationship. This here is buccal cross because the lower is more buccal to its normal position. And this is because the lower is more lingual to its position. Why do we call it scissor bite? What do you mean like scissor?
They cross each other.
They bypass each other. There is no contact. Like the scissors, they bypass each other. There is no contact. So if I look at the buccal crossbite and the lingual crossbite, which one is more functionally demanding treatment? Scissor bite, lingual bite, so basically if I have a bilateral buccal crossbite without mandibular displacement, I could accept. Sometimes I could accept, but a lingual crossbite, where we have no occlusal function, we need to consider treatment. Transverse discrepancy, as we said, it could be local factors related to local crowding, severe displacement of a single tooth. So for example, this one is a crossbite. It could be related to skeletal problems, like for example, narrow maxilla plus minus wide mandible, or the opposite. So it is related to the skeletal discrepancy in the transverse dimension. And usually if this is the case, you will find that the teeth are upright or normal orientation, and the problem is in the skeletal part of the arch. It could be due to soft tissue and habits. Some sucking habits, if you remember, will cause the tongue to go up, and to go down, and we will lose our balancing zone, and we will end up with a narrow maxilla. So it could be due to habits. Rare causes, collective impalate cases, pathology, or trauma. Now the treatment will depend on the severity, will depend on the classification, will depend on the teeth involved, and if it's skeletal or dental. Usually cases with a single tooth in crossbite, simple tipping movement is enough if it's not that severe. With a removable appliance, I could add what active component? Z-spring. If it's in the anterior segment, Z-spring, right? If I have few teeth, more than two teeth, double cantilever in the anterior segment, in the posterior segment, expansion screw, localized to the, for example, if I have here 6, 5, and 4, then I have to cut it here and have my expansion screw only for this block of teeth. Expansion screw for only the affected side. Or I can use cross elastics. Elastic that runs from the palatal surface of the upper buccal teeth, upper molars, to the buccal surface of the lower. From the palatal surface of the upper to the buccal surface of the lower, and this will correct the single tooth and buccal crossbite. So this is an example of a patient, class 1 malocclusion, complicated by crossbite affecting both upper canine and the lateral incisor. So this is the patient at the end of the treatment, correction of the crossbite. If the problem is affecting a whole segment, for example, unilateral buccal crossbite, I need to think, what's the etiology? If it's dental, then easy, I can go with tipping movement. Upper removable appliance with midline expansion screw will do the job. Simple tipping movement. Midline expansion screw, usually buccal capping, and we can actually tip these teeth. So the width of the arch is normal, so there is no skeletal etiology, and we have problem dentally. We tip the teeth, we correct the crossbite. If I need more than 4 mm of expansion, or if the problem is part of it skeletal, and the teeth are upright or normal inclination, and tipping movement will not solve the problem, then I need to think of bodily movement. What we call slow expansion appliance. Like the quad helix, it's a fixed appliance that is used for expansion. Most of the movement is bodily, in theory, and the rest is tipping movement. So this is a quad helix. It is called the quad helix because I have 4 helices. It is fixed, and I can activate it to produce more than 4 mm and hope for bodily movement. If the case is more skeletal and I need to modify the skeletal pattern transversely, then I need to think about rapid maxillary expansion. Since I have slow, most probably I have rapid. We call it RPE or RNE, rapid palatal expansion or rapid maxillary expansion. This appliance should be used in patients who are younger than 15 years old because I need the mid-palatal suture to be still open, not fused, okay? And the idea is resembling what we call distraction osteogenesis, where I have a suture that I open and hope for new bone to develop and form within the suture. Usually the patient has to open this, of course if it's fixed, the rapid palatal expansion is fixed. It could be capping with banded, not bonded. The patient should activate it twice a day. Twice a day. Removal appliance, once to twice a week. Quad helix activated by the clinician himself. Okay? But rapid palatal expansion is activated by the patient twice a day for 2 weeks. Each turn, 1/4 millimeter. So each day, 1/2 millimeter. 14 days, 7 millimeters, right? So I expect 7 millimeter of expansion within 2 weeks. After that, this should be followed by several months of retention. After I achieve the correction, and it is advised to go for overcorrection. So this appliance is supposed to give me skeletal modification, but actually part of it is going to be bodily and sometimes tipping movement. It's not avoidable. It could be part of the treatment. So this is an example of a patient. This is why we call it black corridors. Black corridors is usually associated with a patient with narrow maxilla, bilateral buccal crossbite. Bilateral buccal crossbite should not be treated by the general dentist with simple removal appliance. Never, because if you fail, you will transfer the patient from a non-functioning case that requires treatment to a case with unilateral crossbite and mandibular displacement. Because as we said, bilateral crossbite is stable. In terms of function, in terms of temporomandibular joint, it's stable, no problem. No functional need. But if you fail to treat it fully, it will be converted to unilateral crossbite with mandibular displacement. So this should be treated by the orthodontist using fixed appliances, bodily movement to correct the crossbite. You can see part of the black corridor was corrected, non-extraction, expansion, and bilateral crossbite was corrected as well. Now the last clinical case is the bimaxillary proclination. Bimaxillary proclination, we talked about the etiology, if you remember. The etiology is mainly soft tissues, incompetent lips, flaccid lips, low tonicity, everted. Okay? And it is very difficult to treat because if you don't remove the etiology, it will relapse. Can I remove flaccid lips? Low tonicity? Maybe incompetent lips could be treated, maybe. Maybe crowding could be treated, and this will help with the retraction of the teeth. But I need to be very careful with the retention. So these cases are difficult to treat. You need to plan it carefully. Usually it's common in Afro-Caribbean, although the incisor relationship is a class 1, but the overjut is increased due to the inclination of the upper and the lower incisors. Management, as I said, is difficult because of the relapse, because the teeth are in the balance zone was disturbed. The tongue is winning, teeth are pushed by the tongue. If you don't correct this, then you need to consider permanent retention. Otherwise, it will relapse. If it's mild, we need to encourage the patient to accept again because of the problem of relapse. Stability, as we said, is a problem. And lips, if we start on incompetent lips, then we have better prognosis. Because if we achieve competent lips at the end, this will aid for stability. Crowding and spacing will affect the type of appliance used and the retention after treatment. This is an example of a patient. This is a patient presented with a class 1 malocclusion complicated by maxillary proclination. Right? But this patient has nearly normal lips, a little bit of strain with her mentalis muscle to close, so she has nearly incompetent lips, but they are of normal thickness. Plus, we have crowding. So treatment for this patient should have good prognosis. Why? extraction, retroclination of the upper and the lower segment, and we expect a more relaxed soft tissues. So this is extraction of a premolar in each quadrant, space closure, arch coordination, and this is at the end of the treatment. So you can see her smiling much better, and you can see her profile much relaxed. Now she has competent lips. Now this will aid for the stability of the treatment. So these were different cases, but does that mean that when I have a case, it will have only one problem? We can have cases that has multiple problems. Yeah, a patient with a class 1 malocclusion complicated by maxillary proclamation. All agree? No. Unilateral crossbar actually isn't unilateral? Bilateral buccal crossbar. What else? Anterior open bar. What else? Well, yes, but it's not due to trauma. This is poor. This is the remaining root. Can you see the remaining root? So it's almost all problems, class 1 malocclusion altogether. Vertical dimension, anterior open bar. Transverse dimension, crossbar. Localized space, yes. We have lateral missing crown due to poor prognosis and remaining root. So, what do you think the treatment should be? Well, yeah, skeletal tissue is normal. Soft tissue is normal. Yes. So you will go with? Well, extraction is a borderline, right? Plus, I'm going to expand to correct the crossbite. Expansion will give me space. This will correct the crowding, it will correct the proclination, and it will give me more space to replace the missing lateral incisor. Bimaxillary proclination, anterior open bite, crossbite, and localized spacing in the same patient, all in one. So this is the patient in the middle of the treatment. Of course, the correction of the anterior open bite was a combination of a little bit of extrusion of the anterior teeth and a little bit of intrusion of the posterior teeth. And this is the prosthetic lateral. I usually add it, especially in females, because with a gap, they are not satisfied. And they will rush you into treatment. They say, when am I going to finish? Right? Every visit. So it's easier to go with a prosthetic lateral. I add it to the arch wire, and then the patient will be quiet for a few visits. They will not ask when they're going to finish. I make sure that I have parallel roots, and then I go with the deboned. This is the Essex with the prosthetic lateral, and now the patient is ready for any future implant or a prosthetic replacement, fixed or removable. Right? Any question about class 1 malocclusion? Yes. Anterior open bite. شو بعرف من class 1؟ ايش اهم feature بالclass 1 malocclusion? Yes, absolutely. So we look at the lower incisor edge single implant of the upper. It's okay, imaginary line. عشان هيك دكتور تعريف الكلاس 1 incisor relationship هو when the lower incisor edge occludes at or immediately below. ليش حكوا at or immediately below؟ إن أنت بتحط imaginary line، مش بالضروري يكون at، مش ضروري يكون بالنص اللي فوق، ممكن يكون immediately below. تمام؟
below the single.
No. below يعني ممكن يكون severe anterior open bite ولسه class 1 اسمه. تمام؟ Any other questions? I think you already started your clinics. You already started filling your examination forms. Next clinic is going to be, well, actually this week clinic is going to be class 1 malocclusion complicated by crowding. So basically we're trying to make parallel lectures مع اللي بتاخذوه بالكلينيك عشان يكون اسهل تطبقوا اللي عم تسمعوا. اموركم تمام؟ اوكي، يعطيك العافيه، شكرا. لحقوا صلاه العصر.
Thank you.